Good afternoon, Dr. Wilde. Can you hear me?
Yes, I can, sir.
Now, I'm glad that you are now on a large screen facing the audience here in Fleetbank House, a select band of interested people. You won't be able to see them for particular reasons, but you should know that in this room there is counsel who will be asking you some questions in a moment or two after you have been sworn. She is in the front row of a number of rows which contain a few legal representatives. There are representatives of the press in a corner of the room, shorthand writer and a technician whose job it is to display to us documents which you will see at your end. You're being followed remotely by a very much larger number of people of various different interests, so your evidence will be screened to them as you give it, or shortly after you've given it. There'll be a brief time lag before they see it. You're our first witness to be heard remotely. I'm sorry that you can't be with us because of the COVID restrictions, but thank you very much for giving evidence from where you are. I will start.
Well, thank you for allowing me to do so.
Not at all. You'll be sworn in a moment, and after that, the next person you see or hear from will be counsel to the inquiry who will ask you the questions. Mary?
Please state your full name.
Dr. Jonathan Thornton Wilde.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Dr. Wilde, can you see and hear me?
Yes, now, yes.
I'm going to start just by asking you some general questions about your career. You became, I think, a haematology registrar in 1984.
Yes.
And you worked at the Northern General Hospital in Sheffield in that capacity between 1984 and 1986. But as I understand it, you weren't involved in the care of patients with bleeding disorders at that hospital.
No.
You then, in 1986, October 1986, took up a role as a lecturer in haematology at the Royal Hallamshire Hospital.
I think it was earlier that year. I think it was March 1986.
Can you just help us with this? I think the job title's lecturer, and we've heard that from other witnesses, but it was essentially a clinical rather than academic post. Is that correct?
Well, no, it was predominantly an academic post. I was the first lecturer in that department and was employed by the University of Sheffield within the Department of Haematology in the Royal Hallamshire Hospital. And so my predominant role was research in preparation for my MD thesis.
And you continued in that role until 1988?
Yes.
And to what extent at the Royal Hallamshire, I think your statement describes some clinical work at the Hemophilia Centre under Professor Preston, is that correct?
Yes, so I was given responsibility for running the weekly haemophilia or bleeding disorder clinic with the unit sister, and I also had on-call commitments on the on-call rota with the registrars and senior registrars.
And then you moved to the Royal Liverpool Hospital, where you were from 1988 to 1992.
Yes.
And that was as a senior registrar. I think you refer to Professor Hay having been the director at the time, or the consultant at the time. To what extent did you have clinical responsibilities during that position?
I can't remember the exact dates of rotation, but we did rotate around the main hospital to Alder Hay for 6 months, to the blood transfusion service for 6 months, and to one of the district general hospitals for 6 months. So I think I was in the Royal Liverpool Hospital for around 2 years, and the first time there, probably for about, say, up to 18 months, I was predominantly involved in the care of patients on the wards and in the laboratory. And it was really only, and I think I was doing some haemophilia related work at that time, especially when there'd be inpatients. But once I got my MRC path examination around 18 months into the job, I then expressed a wish to have more of an interest in the bleeding disorders service, and therefore joined Dr. Hay, and I'd sit in on his clinics. I must have done some clinics when he was away, and obviously taken more responsibility for the bleeding disorder patients at that time, both in the clinic, on the wards, and obviously out of hours.
And then in November of 1992, you moved to the Queen Elizabeth Hospital in Birmingham as consultant and director of the Haemophilia Centre.
Yes.
And
in fact, interesting, my job description was specifically solely for being the director of haemophilia, but the circumstances at the time were such that I did get involved in other aspects of haematology within that department.
And you remained in that post until your retirement in 2016.
Yes.
You were, in that capacity, you were a member of UKHCDO and some of its working parties, and we can come on to consider those in due course. Can you describe in broad terms what the facilities and services were at the Haemophilia Centre at the Queen Elizabeth when you took up your post in 1992?
Yes. At that time, the unit had evolved over the previous few years. Once extra funding had been found to run the service, so we were fortunate in that we had 2 rooms on the 3rd floor of the Queen Elizabeth Hospital. One was an office stroke meeting room where all the patient notes were kept, and the other room was a clinical room where we would see patients when they came up outside of clinic times. And the ward was just around the corner for inpatient stays. That was very convenient. And the outpatients they continued where Professor Franklin and Dr. Hill used to do their clinics on the ground floor of the hospital in the haematology outpatient area. So we had a clinic there on a Thursday morning. I was fortunate to have a full-time nursing sister, a full-time staff nurse, a half-time staff nurse, a full-time community sister, and also an excellent social worker. So I think that compared to some other centres in the country, and I'm sure you're aware that there was a great range of facilities available for haemophilia care in the country. But I think that in retrospect, at that time, I was really quite well off in that regard.
And your statement refers to there being regular Thursday lunchtime meetings
Yes.
at which issues relating to patient care or treatments would be discussed. Was that something that had already been taking place, or was that something instituted by you?
No, I'm aware that I'm sure that after their Thursday morning clinic, Professor Hill, Professor Franklin would hold that meeting, and I simply slotted into that when I came along.
Did your appointment overlap at all with Professor Franklin, or had he left by the time you joined?
No, he left, I think, around 3 months before I started.
And roughly how many patients did you have responsibility for, again, when you took up the clinic in 1990, the centre in 1992?
I don't have the exact figures here, and probably the most accurate place to find that would be the Oxford database. but I vaguely recall around 450 patients. That's a very vague recollection of all diagnoses of bleeding disorders who were registered.
I think your statement suggests around 400 when you commenced post, and then it rose, you've said, to around 700 by the time you left in 2016.
Yes, and I think that was simply because I'd obviously accrued transfer patients over from the Children's Hospital, and I was making more diagnoses of bleeding disorders as more and more diagnostic tests and recognition of bleeding disorders came along.
Can I take you back to your time in Sheffield at the Royal Hallamshire Hospital to start with? Your statement says that you've no recollection of the particular policies in place at the Royal Hallamshire for the selection and purchase of products. That would have been the responsibility, would it, of Professor Preston at the time?
Yes.
Presumably by the time you were there, the products would have been all heat treated. Is that correct, in terms of factor concentrates?
Yes.
And your statement suggests you recall the use of DDAVP there, but not cryoprecipitate, and treatment there was not on a prophylactic basis.
Quite correct.
Do you recall receiving any general advice from Professor Preston about treatment of patients with bleeding disorders, or in particular the treatment of patients with HIV?
I mean, not specifically, but I mean, if there were any issues, then he was readily to hand, and also Professor Greaves as well, for me to approach them to give me management guidance on those various issues.
When you started at Sheffield in 1986, presumably some of the patients of the Haemophilia Centre there would have learnt that they were HIV positive as a result of their treatment in the preceding 2 years. Can you recall anything about looking after newly diagnosed or relatively newly diagnosed HIV patients in Sheffield at that time?
I think only that we were monitoring them to a degree. I honestly can't remember specific tests we were doing at that time. I can't honestly recall whether we were doing CD4, CD8 counts. And I think it was a case of listening to them, getting a feel for whether they were getting any symptoms at all, and then examining them to see whether they were getting any manifestations of the disease. And I'll be honest that although we'd had a case through, or we had a case through during my time there, I can't recall any other specific AIDS diagnoses at that particular time, but there might well have been.
Did you learn anything about the circumstances in which those patients had been tested and informed of their diagnosis for HIV?
I cannot recollect that at all. I just I took them over with them knowing their diagnosis.
Sorry, we just had a strange noise on screen. Can you hear us okay? Still,
Yes.
Dr. Wilde? Yeah. Your time at Liverpool would have coincided with the development of the test for the hepatitis C virus. Were you involved at all in arranging for the testing of patients for hepatitis C at Liverpool, or telling them their diagnosis?
I honestly have no recollection of that at all. I think that Dr. Hay was a very hands-on consultant-led consultant, and I think that he took responsibility for that.
And then if we turn then to the Queen Elizabeth Hospital, you've said that as director, so you've said in your statement, as director, you had sole responsibility for choosing which factor concentrates were used. You've said you can't recall specific products, but you've described a general approach in your statement in terms of how you would decide which products to use. You'd look at safety and you'd look at the particular issue of inhibitors. Is that correct?
Yes, I think those were general rules that any director would be employing when they were choosing products.
And you've said that if all things were equal as between those factors, cost would then be the next consideration.
Yes.
By this time, there were guidelines published by UKHCGO or recommendations about products. As far as you can recall, did you tend to try and follow those guidelines?
Yes. I think they came out a bit later, didn't they? Probably mid-90s that they became established and published.
Yeah, there are various versions, but broadly speaking, you would have looked to those guidelines to give you a steer.
Yes, yeah, I mean, they were very broad and, again, leaving a lot to the individual consultant to make the choice.
We've seen evidence in relation to the practices in the West Midlands area in the 1980s that there was a regional contract placed with usually one pharmaceutical company, certainly in the first part of the 80s. And there was a role for the Haemophilia Centre clinicians to adjudicate upon the different bids for that contract. When you took over in 1992, were the contracting arrangements still along those lines, or had they changed?
I'll be perfectly honest that I have no recollection of what the exact mechanisms were. I inherited the pattern of factor concentrate usage that was there and continued with that. And obviously there would have then been changes in time as new products came along, especially when it came to recombinant. But I can't specifically recall direct negotiations with the purchasers as to which products we would choose in relation to others. It sounds somewhat odd, that, but as I say, I've got a feeling, and you'd be able to look at the Oxford returns for what products we were using at that time, but I think that we had a pretty stable usage of products at that particular time, and it might well be, I'm not sure whether the prices did vary from time to time, but I've got a feeling that we were tending to use the products that we were using tended to come in as the cheaper ones on the tenders, and we were sticking with those. I mean, that's my vague recollection.
Now, as we understand it, Professor Hill ceased to do a clinic at the Queen Elizabeth Hospital in 1992 and became full-time at the Children's Hospital. Did you have interactions and discussions with Professor Hill nonetheless, although he was no longer directly involved with your Haemophilia Centre?
We must have had discussions about products that were to be used across the hospital / the region. I think that we probably both took a lead on that as to what products the West Midlands would be purchasing.
Do you recall any discussions with Professor Hill about the events of the 1980s and the circumstances in which so many children at the Children's Hospital had become infected with HIV?
I don't recall any specific discussions with regard to that. I think that when I took over, I just accepted the fact that that was the situation, and I don't think I ever kind of looked into the history of it all.
And you would have had patients coming to you as new patients at your centre who would have been treated at the Children's Hospital and infected with HIV or Hepatitis C as children at the Children's Hospital. Do you recall learning anything from patients or discussing with patients their experiences at the Children's Hospital or their care under Professor Hill?
Not specifically, no. I mean, I obviously had formal referral letters on the patients, which were very detailed, giving me the full details, and obviously giving me the impression in the letters that the patients had been tested for the viruses, and either their parents / themselves had been told the diagnoses.
You've made some reference in your statement to awareness of there having been liver biopsy studies and research into liver damage at the Royal Hallamshire Hospital under Professor Preston and indeed Dr. Hay. Was that something in which you had any involvement at all during your time at the Royal Hallamshire?
No, I didn't. I was solely responsible for the clinic and don't recall any specific involvement in those studies. I think some of them, or a lot of the work, I think, was actually before my time there.
Yes, it was. I'm just wondering whether it had continued at all, but we can ask Professor Preston or Dr. Hay about that next week. And then just still sticking with the Royal Hallamshire for the moment, in terms of the approach to testing patients, I'm not talking here about HIV or hepatitis C testing, but when patients came to the weekly clinics at the Royal Hallamshire Hospital that you were involved with, and you undertook monitoring, testing, liver function tests and the like, can you recall what kind of discussions you had with patients and what kind of information you gave them about the tests?
I think they would have been aware of the tests that were being taken for their monitoring. I think that they'd obviously, prior to me starting, had become familiar with the kinds of tests that were being done, and I mean a number of them showed interest in the test results. I can't specifically recall testing any new patients for the viral illnesses at that particular time.
Your statement says you have a vague recollection at the Royal Hallamshire of there being serum samples frozen and stored. Can you recall any more about that, or what patients were told about that?
I think just as a matter of habit from the clinic, I think an extra sample was taken. I've no idea. It was just something that seemed to be part of the routine blood taking, and I have no recollection of ever having been specifically aware of whether or not the patients had been informed that was the case. I think that time a number of centres were collecting retrospective samples or collecting samples in that way so they could be retrospectively tested in the future to see if new infective agents came along. But I think, again, those are questions that will probably need to be specifically asked for Professor Preston.
In terms of your own practice then as director at Queen Elizabeth, your statement says you didn't have a policy of storing and frozen samples. Is that correct?
No, I think that to me that was full of issues with regard to consent, and I didn't feel it was appropriate to be collecting those samples. In that, I suppose, I mean, you could argue that perhaps this was a bit naive, but I had every confidence that the treatments we were using then were safe and that we would never need to be using those samples anyway.
And as far as you're aware, had there been, or was there when you arrived at the Queen Elizabeth, any existing bank of stored samples?
I cannot recollect that. I can't recollect that there were freezers in the laboratories full of samples that were then thrown out. I have no recollection of that. But I certainly I made a decision as soon as I became a consultant that it was inappropriate to be collecting retrospective samples. And that could be criticised, but as I say, that was my policy.
And then in terms of a routine appointment at the Haemophilia Centre at Queen Elizabeth, once you were director, if you had a new patient or a patient perhaps transferring from the Children's Hospital to your care for the first time, what kind of tests would you be undertaking on a regular basis from 1992 onwards in terms of liver function tests or CD4 counts for the HIV positive patients? Can you give us an overview?
I'd obviously be checking a full blood count, and I'd be checking their clotting factor levels, it would be inevitable that they'd come over from the Children's Hospital or even transferred from other centres with their viral serology having been done, because obviously those tests were available at that time. But I must admit that I would be repeating those tests to make sure that they were genuine, because again, we had a number of false positive tests in the early days of testing, as I'm sure you're aware. I'd test their hepatitis B status as well. I'd do an inhibitor screen to make sure they haven't got antibodies against factor VIII. I'd be doing their liver function tests, as you say, and if they were HIV infected, then obviously starting the monitoring of their CD4, CD8 counts.
And what would you routinely tell such patients about the purpose of such tests?
I'm sure I'd be mentioning that I was repeating the viral tests to make sure that they were obviously, well, to make sure they were genuine. And many of them were aware that they'd been having their liver function tests, CD4, CD8 counts done where they previously were. So I don't think there was anything new that I was having to tell them in that regard to the monitoring.
Do you recall whether you had any patients who had not been tested for HIV and for whom you had to arrange a first test for HIV?
Very occasionally, a patient would come along that had had product that could have put them at risk, and we then had to counsel them with regards to the testing, and then obviously organise the testing and to arrange for them to be informed of the test result in person.
And on those occasions, did you ensure that patients were told in advance that you wished to test them for HIV and that you secured their consent?
Absolutely. In those days, we weren't routinely getting written consent, but I would definitely be making sure that I got oral consent from them for that test.
Now, in terms of hepatitis C, your statement indicates that you thought that the majority of patients had been tested for hepatitis C before you arrived in late 1992. I should say that Professor Franklin doesn't have any recollection, he says, of arranging for tests for hepatitis C. Doing the best you can, Dr. Wilde, what can you recall about the position at Queen Elizabeth as regards hepatitis C testing?
My recollection is that I was seeing patients in the clinic who had already been screened for hepatitis C, and I can see in my mind's eye, I can see the result in the list of results in the patient's notes, together with their HIV test results, their hepatitis B test results. I mean, the test had been available for at least 2 years before then, and I think, and they were definitely being tested at the Children's Hospital. So I think, I have to be honest, that I think it's unlikely that I was inheriting a cohort of adult patients that had not been screened for hepatitis C. If that had been the case, I'd have had a great recollection of having to counsel those people to say that we've now got a test for this new virus that is deemed to be the cause of previously known non-A, non-B hepatitis, and then subsequently testing them and informing them of their results.
There were, I think, some patients who had not been tested and for whom you were arranging tests from, I'm not sure exactly what proportion, but your statement suggests a minority of patients where you had to arrange tests for hepatitis C testing. Is that right?
Yes, these would be patients that will have had product in the past, but were not on a regular follow-up in the clinic. They might have moved address, possibly moved away, and they'd been lost from the follow-up system. And every so often they'd come up and we'd realise that they were potentially at risk because they'd had previous virally inactivated product, and then we'd arrange the testing for them with naturally the full counselling beforehand. But again, I iterate that we were not getting written consent for that testing, and then we'd subsequently inform them of the result in person.
Would it have been your practice to record in the patient's records the pre-test counselling process and the fact that you were arranging for their testing and had sought their consent?
Definitely recorded that they were having a hepatitis C test.
Would you have recorded, as a matter of general practice, I'm not expecting you to be able to remember the details of individuals, but as a matter of general practice, would you have recorded not just the fact of the test, but the fact of a discussion with the patient?
I think at times I'd have used the words fully counselled with regard to hepatitis C, something like that.
What can you recall about telling patients, whether they were patients whose test you'd arranged or patients who had been previously tested but were unaware of their diagnosis, what can you recall about telling patients that they had hepatitis C in the 90s? What kind of information would you provide?
Well, I think that once they had a positive test result, I'd have to inform them that it looked like they got chronically infected with the virus, and that we would continue to monitor them to see whether or not they were going to go on and develop significant liver disease. I think that had to be part of the counselling to them. If they had minimal evidence of any progression, we'd reassure them to that effect. If I was concerned about any of those patients, I would refer them to my hepatology colleagues. I mean, we're talking about this window of time between me starting at the QE and the setting up of this special hepatitis C clinic that I subsequently did. And in that meantime, I think that, as I say, I would still be referring patients I was concerned about to the liver clinic for a more formal workup. And I think that at that time we might have done 1 or 2 liver biopsies to see what the state of the liver was, because I'm sure you're aware at that time that was really the only definitive test we had to determine how progressed the hepatitis C had got in individual patients.
Were the liver biopsies performed by you, or were they undertaken by the specialist liver clinic?
No, they were undertaken by the specialist liver clinic, but obviously with my guidance with regard to appropriate factor concentrate replacement regimen.
And then in terms of the treatments for hepatitis C, which obviously changed significantly over your time as director at the centre, the first treatment routinely used was interferon. What can you recall about your patients' experiences with interferon?
Within that time period when we had interferon on its own, I do recall 1 or 2 patients being offered it by the liver clinic, but on the whole, it was associated with significant side effects and really was very ineffective. And I'm sure you're aware from trials that interferon on its own as a single agent was only giving around a 10% sustained clinical response. I mean, a number of them actually tended to normalise their liver function tests while they were on it, but as soon as they came off it, then the hepatitis C came back. I mean, I think these are the days before we had PCR monitoring to specifically assess the effect of interferon on its own, but it was very ineffective. So patients were going through prolonged treatment, having very bad side effects with, unfortunately, very little success. But then subsequently, of course, ribavirin came along, and the combination of interferon and ribavirin was more superior. And that's around the time when we certainly became more aggressive in our hepatitis C management, because at this stage we'd got some more hopeful therapy. And of course, the hopes of response and sustained remission were improved even greatly when pegylated interferon came along in combination with ribavirin.
And whose responsibility was it as clinician to prescribe the interferon, whether on its own or in combination, and to warn patients of the side effects? Was that you? Was that the hepatologist, or was it a joint exercise?
No, it was the hepatologists would do that.
What were the arrangements, first of all, in the course of the 90s, so from late 92 when you arrived onwards, for screening and following up and observing for signs of liver disease and progression of liver disease?
Well, as I say, I'd be seeing patients in clinic every 6 months and assessing them clinically, doing their tests. And if I was concerned, again, very difficult, you couldn't really tell what was going on actually in the liver at the time. But if I did have any concerns about a patient, then I would refer them directly onto the liver clinic. And as I say, some of those patients then subsequently were worked up and were offered a course of interferon therapy.
And there were, your statement says, some patients who underwent liver transplants in due course.
Well, in fact, interestingly, I'll be honest, I don't think any of the QE patients, in fact, actually got to the stage of liver transplantation. Although we were, I suppose, a national unit for liver transplantation within the Queen Elizabeth Hospital, I don't recollect any of my own patients I was looking after who actually subsequently went on to have a liver transplant.
What were the arrangements for HIV care when you joined in late 1992?
Yeah, the patients were, the HIV infected patients, as you know, were being looked after in the Hemophilia clinic by doctors Professor Franklin, Professor Hill, and I think that Professor Franklin in his evidence gave the impression that the HIV infection was not greatly established within the non-haemophilia patients in the West Midlands at that time. And I think because of my previous experience in haematology, looking after immune-compromised patients, and my experiences in HIV specifically, both at the Hallamshire and the Royal Liverpool Hospital, I was very happy to continue to be looking after the patients, as a number of my colleagues around the country were looking after the HIV aspects of the patient's care. And again, equally, the patients themselves were more than happy to stay within the haemophilia unit because they didn't wish to be going to clinics with the other at-risk group patients. And some of the patients, as you know, did subsequently go their care to either a GU consultant with specialist interest in HIV or an infectious disease consultant who had an interest in HIV. Again, there were specific aspects about the management of HIV that fell under the auspices of haematology. A lot of them had hematological manifestations, which I was readily able to manage. And of course, I'm sure you're aware that the drugs that came along, the protease inhibitors, were associated with a very unusual bleeding pattern in the haemophilia patients, which again was probably better for me to be attempting to manage that. And of course, a lot of the patients also had thrombocytopenia as well, which came under the auspices of haematology. So I had a great interest in HIV, as I'm sure you can tell from my my witness statement and research and papers. And so I was very happy and keen to continue the management of the HIV-infected patient cohort.
In terms of reverting to the HCV patients, although of course many would have been co-infected, your statement puts early 1994 as the date on which the joint clinic with hepatology was established. Is that about right?
Yes, yes. I mean, this was a time when we realised that a lot of patients had treatment during the 1980s and had been lost to follow-up. And I felt it was absolutely vital to be getting all these patients, inviting all these patients up to the hospital for appropriate counselling and screening. And many of them turned out not to actually have hepatitis C, but a considerable number did have hepatitis C, and we were able to then manage them appropriately. And it was around the time when interferon ribavirin came along, and therefore it was it seemed far more appropriate to be more active in managing these patients because we had the chance of actually curing the infection.
And did the arrangement for a joint haemophilia liver clinic continue throughout the time that you were director, or was there a time when those arrangements changed?
I think that, I can't remember the length of that clinic, but the main exercise was to make sure that we captured all patients who were known hepatitis C positive or had been exposed so that we could check whether or not they were hepatitis C infected. And when we'd managed to work through all the patients and manage them as we saw fit at that particular time and offer them, I won't go into the specifics about how we decided whether or not, but as you know, it was liver biopsy guided as to how we managed these patients. But subsequently, we decided that we didn't need to continue with a liver biopsy approach, in that the treatments became far more effective, and it seemed far more appropriate to offer the hepatitis C PCR positive patients the antiviral therapy up front in an attempt to cure them all, even before the minimally or the ones with minimal progression had actually had a chance to progress any further.
What were the arrangements at the centre for the provision of social work support and counselling?
As I say, I was fortunate throughout my career to have a number of excellent social workers, and again, as you know, many of the centres in the country did not have dedicated social workers, and I think these people were invaluable to the service. They provided far more than social support. I mean, they were the principal counsellors within the unit. Admittedly, the nursing staff were excellent as well. They were well trained in the counselling of all the various problems that arose. But the social workers, as they progressed through, were again very experienced. And the social worker I had probably for about 15 to 20 years during the latter part of my career was absolutely brilliant and worth his weight in gold. And I'm sure the patients will iterate that as well.
And you've said in your statement that there was no dedicated counsellor or social worker for the specific care of HIV and HCV infected individuals. And the social worker who you've mentioned was responsible for all components of social care relating to bleeding disorder patients. So it would include, but was not limited to, the particular problems associated with HIV and hepatitis. Is that right?
Yes.
What, if anything, can you recall about the ability to obtain funding for treatments for HIV and for hepatitis C? Did you encounter difficulties?
From my recollection, I can't recall specific issues with regard to HIV, because the HIV budget was funded by the region for all categories of HIV infected patient, and I can't recall any real specific issues with regards to that. And again, the interferon ribavirin was funded via the liver unit. They would obviously apply for funding. I think there were initial, very early on problems with interferon ribavirin, but I think that we were fortunate in that we had permission to use those drugs at a very early stage compared to other units around the country.
In relation to patients, those patients for whom you were arranging their testing for hepatitis C, what were then the arrangements for informing them of a positive test result? Did it wait until the next appointment? Were they called in for a special appointment, notified by letter? How was it undertaken?
No, we'd call them in specially after the test results were available. I certainly wouldn't be leaving it from one clinic to the next to inform them. And certainly when we had the joint clinic, we would either schedule them for a follow-up appointment in that clinic after we tested them, or I'd arrange to see them back in the routine bleeding disorder clinic on a Thursday morning. So I don't recall there being any significant delays between the testing and the information, because we obviously had those people at the top of our minds that we were awaiting test results on them.
For those for whom you were not arranging the testing, but who had been, as far as you understood it, tested for hepatitis C before you joined, did you become aware that there were patients who had been tested for hepatitis C but had not been told their diagnosis, so had not been told the test result?
At the time, I can't recall that was the case. I mean, obviously, some of these comments have come up in witness statements, but at the time, I cannot recall having had patients that had come through who were hepatitis C positive that I wasn't aware that they didn't know that particular diagnosis, but it's possible that was the case.
What if, was there any systematic attempt, whether as part of an organised look-back exercise or otherwise at the Queen Elizabeth Hospital, to identify all patients who might have been exposed to hepatitis C and arrange for them to be tested? And if so, when was that endeavour undertaken?
Well, that's exactly what we did when we set up the joint clinic in 1994. We had a look back through all the patient records. That we had an index system, so we knew who had previously been registered with us and whether or not they'd had clotting factor at the time that they were that they could have potentially been infected. And again, we tasked ourselves with inviting them all up to this joint clinic. And it's possible we might have missed one or two patients, or some of them had moved and we didn't trace them, but I think we did the best we could to identify all those patients and offer them appropriate treatment. And
do you recall very approximately how long that localised look-back exercise took?
Well, I mean, it must have taken a few months, I'd have thought, as we were gearing up to starting that particular clinic. And that would be probably the latter end of 1993. I mean, I think I will just say here that as you're aware, we had this massive HIV problem in Birmingham. And as a single-handed consultant, a vast bulk of my time was taken by managing all the problems that arose. And I think that certainly hepatitis C at that particular time was taking a bit of a back seat, because obviously we had no specific management for those patients. And it was only when I felt I'd got control more of the HIV situation that we realised that there were potentially a lot of people who were HIV negative who could have hepatitis C infection, and that's when we set about setting up this clinic.
Can I ask you to give us an overview of the introduction of recombinant products at Queen Elizabeth Hospital, and what steps were taken to try and obtain funding for recombinant?
I have no specific recollections apart from the fact that, as you're probably aware, the UKHCDO decided we should have this gradual introduction. I think it was a three-tiered approach where the children would be, it would be introduced to the product, the recombinant products first, and then I think it was the younger adults, and then the older adults. So we set about that exercise as outlined by the UKHCDO guidance. I think there were initial problems attempting to get funding for recombinant from the West Midlands region, and you've obviously got a document to that effect. But I don't think those were very lasting. I think that the West Midlands region came on board fairly quickly after discussions with them and agreed to fund the recombinant product.
Now, you were centre director and consultant at the time when the issue of VCJD came to the fore. And I'm just going to ask you to look at a handful of documents with me in relation to that. Henry, could we have, please, BART 40953, please? And I'm hoping this document will appear on your screen as well, Dr. Wilde. Can you see there, Dr. Wilde, minutes of a meeting of the UKHCDO Executive Committee on the 20th of November 1997?
Yes.
And you've said in your statement, we know that you were present, your name is on the list of attendees. You've said on your statement that you recalled attending a meeting in 1997 to discuss the question of VCJD. If we go to the, sorry Henry, it's page 5. And we look at paragraph 13. If you could zoom in on that, please, Henry. We can see there, Dr. Wilde recorded a discussion about providing information to patients. So it reads, the first part of the afternoon session was spent discussing the problems arising from the recent withdrawal by BPL of batches of factor VIII because of possible risk of transmitting VCJD. Dr. Ludlam expressed concern over advice by BPL to haemophilia directors that recipients should not yet be informed. It was acknowledged that there was an ethical problem in that no diagnostic test was available to exclude or confirm infection in these individuals. Furthermore, such information and attendant uncertainty could cause considerable distress to recipients and their families. Professor Lee felt that the responsibility for disclosing such information should rest with the centre directors and suggested that they should at least make a record in the case notes. Professor Savage indicated it would be better to inform the patients. Professor Lee suggested the UKHCDO should prepare a paper for the Haemophilia Society. Dr. Main suggested that other blood products should also be brought to the attention of hospitals' transfusion committees. So we can see there, Dr. Wilde, I think, a debate over the question of what information to provide and or whether to provide information to recipients of particular batches. Can you recall anything about your views at that time of those concerns?
I think that, as I say, the situation was far from clear at that time as to, it was purely hypothetical that VCJD could be transmitted. And as you're probably aware, it was the East Lothian Health Authority Ethical Board that had stated that the patient should not be informed, and that was obviously passed on to BPL themselves. And I think that the majority of us at that meeting were of the opinion that we should just await developments, and rather than jumping the gun and informing patients until we had more information about the potential for a variant CJD transmission. So my view was just to hold fire and wait and see.
That was November 1997. We can see there was a West Midlands meeting in January 1998. Henry, could we have BWCT 5036, please? So we can see, Dr. Wilde, this is the West Midlands Regional Working Party on the treatment of haemophilia. We've looked at minutes of this working party from the 80s with Professor Franklin yesterday and today. Dr. Hill's in attendance, you're in attendance, and we can see from the first paragraph that the meeting's been called to consider recombinant, because there'd been a refusal to fund it, but also to consider the issue of VCJD transmission. Henry, could we go to the next page, please? The paragraph halfway down the page, beginning Dr. Wilde reported, could we just zoom in on that? The minutes contain various different clinicians reporting the current situation in their units, and this is yours, and you deal here with both recombinant and the VCJD issue. You say, the minutes say, Dr. Wilde reported that the QE Haemophilia Centre was grossly overspent. Until this financial year, the contract with the purchasers for provision of haemophilia services had been largely open-ended, but the hospital had signed off the contract with the purchasers for the current financial year without Dr. Wilde's knowledge, and the agreed budget had been set too low. In addition, considerable expense had been incurred in the purchase of recombinant factor 7A for the management of a patient with a factor VIII inhibitor. The QE chief executive had subsequently instructed Dr. Wilde to postpone any elective surgery for haemophilia patients for the time being. He had also advised Dr. Wilde not to inform the relevant patients that they had received factor concentrate from the batches recalled by BPL. Dr. Wilde and the chief executive were due to have a further meeting to discuss the present situation within the next few weeks. Patients have been discussing the potential problem of new variant CJD. Some wish to change to American concentrate, where others were happy to remain on Replinate. And then the minutes refer to an offer from Alpha to supply high purity concentrate. Now, can I just ask you about the various matters set out in that record? First of all, can you recall anything about the issue about the contract and the Haemophilia Centre being overspent?
I think that this was a new, from what I recall, this was a new chief executive who was a clinician, and I think he ran a very tight ship, and he was acutely aware of the vast expense of haemophilia as part of the trust budget, and I think he wanted to make sure that he had the monies to finance haemophilia during that subsequent financial year, or during that financial year, and therefore it seems like taking it upon himself to have made sure that a contract was signed for that amount of money to ensure that money was there. I don't think that it was appreciated that the West Midlands, certainly the people I dealt with at the West Midlands region were, and I have to say this, that right the way through they were very fair and they were very amenable, very good to work with. They appreciated the ups and downs of the cost of haemophilia treatments from year to year. You could not budget / predict. And therefore we had this, as I said at the top, an open-ending agreement, whereas if we were underspent in a year, they'd claw monies back. If we were overspent, then they would make sure monies were available. And that arrangement was in existence up until this particular financial year, and subsequently carried on in the future. And it was very advantageous to all of us within all the treaters within the West Midlands. But as I say, at this particular time, obviously, unbeknown to me, there was a fixed amount of money in the pot. And I wasn't aware at the time that any more monies would be made available. So I had to placate the trust executive. I had to make sure that there was a clawback on the use of concentrate, make it more economical. And in fact, as it transpired, this was just a little blip by an expensive inhibitor patient early on in the year. And of course, that was the problem, that this was early on in the financial year, which looked as if the projected overspend was going to be massive. But that problem sorted itself out, and we managed to get back on course such that we came within budget during that particular financial year. So that's to explain the economics in that regard.
And then the advice that you were apparently given by the chief executive not to inform the relevant patients that they'd received factor concentrate from the batches recalled by BPL. Can you recall what the concerns were from the chief executive's perspective and whether you accepted and adhered to that advice?
I must admit that was my opinion at the particular time, and I think he was a clinician who was obviously acutely aware of the potential for giving information about a hypothetical situation and causing undue concern and alarm, and therefore he gave me that directive, which I must admit that I did go along with.
Now, we know that in 2001 there was a process that you were involved with in notifying patients about VCJD. Could we go to WITN 1387003, please, Henry? And if we go to the next page, we can see this is a letter from you dated the 29th of January 2001. The subject is new variant CJD and BPL factor concentrates. You have set out in the letter some information about new variant CJD. So far, approximately 80 people in the UK have been diagnosed as having NVCJD. However, there's no evidence that this condition is transmissible by blood or blood products. No patient with haemophilia has been reported as having developed variant CJD. And then you say, we've recently been informed by the UK Bioproducts Laboratory that some batches of factor 8 and factor 9 concentrate made by them in 1996 and 1997 contained plasma from a blood donor who's recently developed new variant CJD. I'm writing to inform you that having checked through our records, it would appear that you've received product from one of the implicated batches. Now, pausing there, does that second paragraph refer to the discussions about product recall that we've already looked at from 1997 and 1998, or was this a further problem that had come to your attention?
There were more batches that were subsequently found by BPL, and of course there was a change in the stance of the UK HCDO then, such that the guidance decided, or rather they decided as a group, that we should ignore the East Lothian advice, and it was then up to ourselves to decide whether or not we should be informing patients. And a number of my patients were aware of the variant CJD issue, so I'd made a decision, as many of my colleagues around the country did, that we should start to inform our patients about this particular situation. So I think it was the fact that there were more batches that were implicated, and that potentially meant there were more patients who had these batches and were therefore potentially at risk of the infection. So my stance, and this letter is actually a UK CDO letter that was drafted. I'm not sure who actually wrote it, but the chairman allowed us to use the letter, but putting our own hospital header on it for the circulation to patients. And I'd made a decision that I was going to let all my patients know whether or not they had received implicated batch. Some of my colleagues decided that they would throw it to the patients and ask them whether or not they wanted to know. And I think that one or two colleagues perhaps decided still to defer and not to actually let patients or inform patients of this situation.
And you refer in the third paragraph, or the standard letter refers to an information sheet from the an information sheet about VCJD, and a statement drafted by the Haemophilia Society, which we've got on the following 2 pages. Now, do you recall what the reaction of patients receiving this letter was? Without identifying any single patient, what was the overall reaction? Can you recall?
I think the patients took it remarkably stoically, in fact. I think they're, on the whole, a very pragmatic bunch. They'd already been through HIV, stroke, hepatitis C, and I think their attitude was, oh yeah, another possible infection. And I think that, I tried to reassure them, because obviously many of them had direct communication with me, personal conversations. And again, we had to reiterate. Just to say that right from the start, that I was never really concerned that variant CJD was going to be a problem. I felt that the way that the blood was being processed and produced, that it was very unlikely that this prion protein would actually get into the factor supply. And I was really, I suppose, trying to reassure them in that regard, that I felt obliged to inform them of the risk, but that so far none of the patients who received these products had actually gone on to develop variant CJD. And because of the time lag then between the donations and the information being sent to them, it was getting to the extreme limit of the conventional incubation for the variant CJD infection.
There's a document you completed, a Haemophilia Society questionnaire. I just wanted to ask you about. Henry, it's HSOC 304241. So we can see this is completed by you. It's a Haemophilia Society questionnaire. The date looks as though it's the 17th of December 2001. It says, looking back to the period from January 2001, following notification from BPL that a plasma donor had been diagnosed with VCJD, and then you're asked a series of questions, you received the information from BPL, your patients were affected. And then there's this question. Did you notify, A, only those who'd received implicated product, or B, did you notify your whole patient group? And you've ticked whole patient group, and the reasons are given: blanket informing of patients preferred, in particular non-affected patients, to reassure them. Can I just ask you to explain what that refers to and what your reasoning was?
Right. So I sent out that letter to the individuals who we'd identified as receiving the implicated batches, but I also sent out a letter to individuals who had not had implicated batches. They might not have even ever had NHS concentrate anyway, and that was a case of telling them. And of course, equally, I decided this had to be done by letter, because we couldn't possibly get all the patients up individually to counsel them in person in a short period of time, because it was absolutely vital, especially from the health issues, the public health issues that arose, that we should inform them immediately, really. And the best way of doing that, we felt, on balance, was by letter. So that was my thinking.
And then if we go to the third page, please, Henry. The questions asked at the top, if the situation arose again, what, if anything, would you do differently, or do you feel could have been improved about the response? And you've said, ideally, personal counselling, but as so many patients affected, this was simply not possible due to the immediacy of information dissemination required.
I think that sums up what I've just said in my statement.
And then there was a 2009 notification. There may have been others as well, but if we just go to, so I'll just find the reference. Henry, it's ABMU 5060. You've said in your statement that you vaguely recall a 2009 letter, which I think you decided not to send. Is that correct?
Yes, I think many of my colleagues decided not to send it as well because, again, it was quite an out of the blue letter, really. And as you see, the date February 2009 was getting on for well, I mean, it was 10 years really since the original notification, and I felt this letter was very well, somewhat confusing and potentially alarmist to the patient group. I don't think we were under any definitive obligation to send this letter out.
And just so that we can see, it's a letter from the Health Protection Agency to all UK haemophilia centre doctors. Post-mortem finding of asymptomatic variant CJD abnormal prion protein in a person with haemophilia. And it records that a person with haemophilia had been found to have evidence of infection with the agent that causes VCJD in his spleen at post-mortem. And then it refers to that patient having been treated with batches of UK source clotting factors, including one that was manufactured using plasma from a donor who went on to develop VCJD. The haemophilia patient, so the plasma donor developed some symptoms of VCJD. The haemophilia patient was in his 70s when he died of a condition unrelated to VCJD, 11 years and 1 month after receiving the batch of implicated factor VIII. He had no signs or symptoms of VCJD or other neurological disease when alive. So you took the decision not to send this. Do you know what the pattern was more generally across your fellow haemophilia centre directors?
I can't specifically answer that, and I think you'd have to ask the individual directors as you interview them. My vague recollection is that not many of my colleagues would have sent this out to patients.
There was a further letter from the Health Protection Agency in June of that year, HSOC 302429. Do you have that, Henry? HSOC 0002429. Thank you. And this is a follow-up letter about the same patient, reporting that there'd been investigations into the possible routes of infection for the patient. And if we go on to the following page, we can see a risk assessment concludes, and it's the bit in bold in the third paragraph, the patient was more likely to have been infected by a batch of factor VIII that was not sourced from a pool containing plasma from the donor known to have VCJD than by one of the 2 batches sourced from the pool containing plasma from the known donor who did develop clinical VCJD. As you had not sent out the February 2009 letter, does it follow that you didn't send out this letter?
No, I thought this was a letter of information to the directors rather than to be sending it to patients. Is that correct? I might be...
That may well be right. It's certainly addressed to directors. If we go on
Yes.
to the third page, there's a bit about other information that patients may wish to know toward the bottom of the page, Henry.
I think it was more giving us information that we could or we may or may not wish to pass on to patients. I took this to mean, this study to mean that it was perhaps likely that there could be variant CJD in donors who did not go on to develop variant CJD, either that there may well be individuals who've actually got the prion protein but simply don't progress to variant CJD, which obviously is quite concerning because obviously those donors could potentially, hypothetically, be asymptomatic and continuing to potentially infect the donor pool. But as I say, I thought this was all hypothetical and again, I iterate that this was so far down the line beyond the potential for variant CJD to the incubation period for variant CJD, that I didn't get over concerned about it within my patient group.
So I note the time. I'm going to move on to a different topic. I have a few further questions for Dr. Wilde, not many, but I need to have the opportunity to ascertain from legal representatives of core participants if they've anything further to suggest. So could we take the break at this point, perhaps for 30 minutes?
Yes, well, we'll come back then at just after 3:45. So 3:45.
Okay, so in half an hour's time, Dr. Wilde, we'll resume.
Dr. Wilde, we often have a break in the mid-afternoon, in fact, normally, and in this occasion we'll have a break for half an hour. I hope that's all right. We look forward to seeing you back online at 3:45.
Okay, thank you very much.
That you're giving evidence, you should not discuss with anyone, whoever they happen to be, the evidence which you have given or which you think you may yet be asked to give.
No, that's fine. Okay, I'm aware of that.
Thank you.
Thank you very much. Okay.